Hey, everybody. Welcome to our latest episode of Autism Confidential. I'm Jill Escher, president of National Council on Severe Autism, and I am your host today. I'm super excited. We have a wonderful guest today. He was actually on the founding board of NCSA, and he's so busy. He's no longer on our board, but doing things that are even more amazing, which you are about to hear about. Dr. Matthew Siegel from Maine Behavioral Health. He is a child psychiatrist, and he is the chief of medical affairs for Maine Behavioral Health up there in the north. And what we are going to talk about today is his efforts in creating an autism center there that serves people with severe autism, which we don't see a lot. Okay, welcome.
Thank you. Thanks for having me, Jill.
Very happy to have you. So let's just start off with a little bit about you. You've been in the field of obviously child psychiatry and autism for a while. Can you just give us a little bit about your background?
Sure. So I trained in child psychiatry and pediatrics, which ended up being a good nexus because, as we all know, developmental challenges like autism kind of sit at that nexus of behavioral health and medical health and involve both. And so, and I was very interested in kids at that time with autism, now kids and adults. And this was about 20 years ago, kind of just as I think the autism wave was starting to break and become more known. So I did my training in those areas, and then was fortunate enough to see an opportunity up in Maine, in Portland, Maine, to do this work. And so moved here and have been doing it since.
And your center is known for having one of the few inpatient units that serve people. It was children, now it's children and adults with autism. Yeah, can you tell
Yes,
us about it?
yes. So the inpatient unit, which is part of our continuum of care that I'll tell you about. The inpatient unit itself serves youth only. We don't yet, a gap within our system is we don't yet have an inpatient for adults, although it's something we're working on. But yes, so we started off, we kind of built this system frankly, backwards from how you should do it. We started with the highest level of care, the most expensive, most intensive, and then built downward. Usually you should sort of start with your more basic care and build upward, but that's what we did. So yes, we have a child and adolescent inpatient unit in a psychiatric hospital. That is the admission criteria to that unit is you must have either autism or intellectual disability or both, and people are typically admitted because of externalizing behavior, so aggression, self-injury, tantrums, etc. They almost always, though not always, have a diagnosable co-occurring psychiatric disorder, whether that's anxiety, depression, whatever it is. But as you, and certainly I think people listening to this podcast likely know, the reason they're presenting is usually because they're having behaviors that are unsafe, and so that's what brings them to our hospital unit. And it
And
was
do
a bit
these
of a
people come just from Maine? Do they come from all over the Northeast? Where do the patients come from?
Yeah, so it's almost entirely Maine, because we have 12 beds and we're full basically all the time. There have been moments in the past where we've been able to admit a child from out of state, but that's really been the exception, not the rule, and not because of preference, but just because we get filled with kids from Maine, and so this inpatient work. So our unit opened 14 years ago or 15 years ago. And at that time, there were about 6 or 7 of these units in the country. I think happily, though there's certainly not enough, the number of these units has increased pretty dramatically in the past decade. And so there's now somewhere between 15 to 18 of them in the country. And there's several states that are opening new ones. It really used to be restricted to almost entirely just a few states in New England, and now we're getting some spread, though certainly not enough by any means.
Mhm. So you offer inpatient services and outpatient services. The outpatient services serve children and adults, and currently inpatient serves children. And that's defined what age? What?
20 and under. 20 and under. Yeah,
Okay.
yeah. Yeah, in our so just to say, so I use this term, a continuum of care. So what do I mean by that? So what we've built over the past 15 years is we started with that inpatient unit, and then we've extended to where we have a continuum, meaning different levels of intensity of care based on what the need is. And so there's the inpatient, that's the most intense, that's like 30-day stay on average, and 24 hours a day in a hospital unit, psychiatric hospital unit. We have a partial hospital program, so that's 6 hours a day, 5 days a week, and the average stay there is probably 4 to 6 weeks. Then we have day treatment programs, which are really like specialized school placements, is essentially what they are. So we run a couple of those for K through 12 age and then preschool. We also now have started an in-home program for toddlers with autism to do intensive, treatment in the home for very young children. And then, as you said, we have a whole outpatient service, which is a very large outpatient clinic that has multiple different disciplines in it, from psychiatry to speech to occupational therapy to psychologists, behavior analysts, et cetera. And so that's kind of our even though it's specialized, that's our most basic level of care, where you might be coming to see a therapist once a week or a psychiatrist once a month, or and you're only seeing who you need to see in that clinic. It's not, I guess one thing I'll say is it's not, we very purposely did not set up a clinic where the whole point is you come in and you get a giant evaluation for half a day or a day, and then you go home with a 20-page report, and then you have no one to do those things that the report recommends. Those are great, but our goal was treatment. And so you come in, you get an assessment, it's brief, and then you see who you need to see.
That is truly an astonishing continuum of care. I mean, I can't think of another site in the US that offers that wide range, a wide range of options for people with severe autism, frankly. By the way, going back, you mentioned that now there may be, what, 12 to 14?
Yeah, more like 15 to 18.
15 to 18. Okay, sorry. Is there a list where people can get, the names of all of those programs?
That is a great question, and it's such a basic need, and the answer is kind of no, actually, which I say with embarrassment. However, we're on the cusp of addressing it. So we put together a research network of 6 of those units that has been running since 2013. We have a web page that at least lists those units, and I believe off the top of my head that web page is I think it's www.mainehealth.org/ADDIRC, ADDIRC, I believe is what the web address is off the top of my head. And so that lists those 6 research units, are units where we're doing research, or we're part of that association. But we are currently putting together a new association that or group that is not research focused, but it's more best practice focused to support each other, because these are very specialized units doing challenging work. And the intention is for that group to include anyone, to include all these units. And part of that effort, Jill, is to have a new web page that will have everybody listed. It's not up yet, but we're working on that. But yes,
People will be very interested in that.
Good. And just to be, you were very kind to say, to say what you said about our continuum of care. And but just to note, there are other places in the country that have excellent continuums of care and extensive, like Johns Hopkins Kennedy Krieger, has a very extensive continuum We may not have all the same elements, but there are certainly really, I can't let you say we're the only ones. So
Can you do me a favor? And can you sort of paint a picture of, it's hard to say, there's never a typical autism case, right? But give us a sense of like what is happening with the individual and the family when they first contact you. And then they enter the system, tell us what happens within the system, and then tell us what happens after discharge. I realize every case is different, but if you can maybe give us an example or two.
sure. And it really depends where they're entering that continuum. So are they unknown to us, they're in extremis and they come into the inpatient unit, that highest level of care, or are they coming in, to the outpatient level? So maybe I'll do one of each. I mean, just so because they are kind of different. So the inpatient level can often be someone who's already in our system of care, but for whatever reason, things are not going well, and we need to do more intensive work with them and support them more. And so they will come into our inpatient unit, usually through a direct admission. In other words, they don't have to go through the emergency room. We just get a referral and we just take them in directly, because as you know, and your listeners know, no one wants to go to the emergency room, and usually nothing good is happening there for anybody. Although sometimes that's the only choice. But anyway, we've been able to avoid that mostly here in Maine. And so they'll come into the inpatient unit, and essentially we start a very rapid assessment and stabilization kind of work. And so in those first couple of days, you're basically getting a full look from all these different providers. So psychiatry, behavior analysts, speech, OT, special education, social work, and we're just trying to assess what's going on with this individual and the family.
So you
And
mentioned it's usually these what are called technically these externalizing behaviors. So
yes,
aggression, property destruction,
yes,
pica, vocalizations, self-injury.
yes, threatening, posturing, self-harm, and then plus minus, what you might call more mental health symptoms. Sometimes people come in with very severe OCD, or they're stuck in the bathroom for 6 hours a day, or or occasionally, rarely, psychosis or mania. So some other things like that. Yeah, so we're trying to assess fairly rapidly what is always a very complicated picture. By the time they get to that level of care, they've typically had multiple meds. They've often had good ABA. And I think that is maybe that's a takeaway for this. Is I think what we have learned over time is that for the kids in this case who reach that level, but I think it'd be true for adults too, is they may very well have gotten excellent med management or excellent ABA, or had a good speech pathologist or whatever it is, but the even excellent work from one discipline is not enough. That they could, by the time they get that level, there's multiple factors going on, multiple problems. If it's behavior, it's acquired multiple functions. And so, you really need to kind of bring in a big team, look at all the various factors, and then try to figure out what you're going to work on. And that's kind
And
of been a learning.
presumably there's also a medical workup to make sure it's
Mhm.
not like a dental thing or, a
Exactly.
pain somewhere, right?
Yes, thank you. If I didn't mention that, but yes, that is part of it. And every year we come up with a couple kind of occult, dental abscesses, or someone who is totally blocked up GI, that kind of thing. So yes, that's a very important part. And then so that's the inpatient, and I guess so. Then we do treatment. The average is about 30 to 40 days in the non-COVID times. In COVID times, we have discharge problems, so our length of stay has been going up, which is not good, but typically 30 to 40 days. And then discharge is
And then I presumably, I don't like the word experimenting, but you're trying different medications and you're using behavioral approaches, sensory approaches. Like what what's the typical pattern look like in terms of that treatment?
yeah. So the typical pattern is someone will come in and they have, one or more significant behavioral symptoms that we're seeing. So aggression or self-injury, tantrums, et cetera. And then that will typically, they come in and we kind of let that go on in a sense. Like, in other words, they don't come in and we start hitting them with a bunch of stuff, because then we have nothing to observe and see. So, we don't want someone to suffer, obviously, but on the flip side, by the time they come to us, this stuff's been going on for a long time, typically. And so taking a couple days to see it and assess it, and obviously we're going to try to keep the person safe, but we need to see what's going on. So in other words, we don't start giving them medicine or stuff like that. We really observe and take history and discuss and examine. And then what it comes down to, kind of the crux of the program, is an individualized behavior. So we do an FBA, individualized behavior plan. We build into that behavior plan all the interventions that seem to be helpful. So if there's a speech or communication intervention, an FCT intervention, that gets built into the behavior plan. If there's no T intervention, that gets built in. So then you have a behavior plan that we start doing, and we have all the staff doing the same 24 hours a day, ideally. And at the same time, I'd say the other pillar is very careful consideration of medication. And there are some people who go through with no meds, and a fair number who receive one or more medications. And although I will also say that often that first couple weeks is stripping away medications that have not been working. And we've had some cases where all we needed to do was strip away the medication, and they got better, but that was the minority. So that's kind of the process there. And so typically what we will see is this. So the behaviors will go up and down day to day, but we're looking for a decrease over time. And that's really important, because what we've learned to do, and what's very hard to do, I think, in community practice, so outside the hospital, very hard to do, is don't react to the last 24 hours. In the picture of 40 days, last 24 hours has very little meaning, particularly for behaviors that have been going on for months and years, right? Why would that matter? And almost no behavior, certainly at this level, is going to extinguish or just change and be the same. Even if we have the perfect behavior plan, it's going to lower in frequency or lower in intensity, and there's going to be ups and downs. And so that's, and that may sound obvious, perhaps, but that's not how hospitals and the medical field, I would say, sort of is trained. Like, you react to what's going on now. And so you have to kind of step back and look at that picture over time. And because it really doesn't matter if yesterday was a worse day, if we are doing better over the last 7 days. Like, we need to see where we're going.
So
And
you're
so
taking
then,
a lot of data and you're
yes,
probably plotting it in some fashion to be able to
yes.
assess whether there's progress or not.
Exactly. I'm sorry. I'm so deep in it. I didn't, think to say that to you. So yes, it's an ABA based program. So target behaviors are defined, behavior analysis goes on, data is taken 24 hours a day on up to 5 typically behaviors. And then we review the data 5 days a week. So which is good, but we have to fight that urge to respond to the last 24 hours. But yes, so very intensive data kind of use. And then what we tend to see is people don't go to zero, and we're not looking for them to go to zero in that hospital program. We're looking for them to get safe enough that we can step out of the hospital. And in non-COVID times, that discharge is typically us helping to line up in-home services. So in Maine, we have a couple Medicaid-funded services that are very good when they're available, which is basically having a RBT or BHP in the home who's overseen
That's
by a
a registered
BCBA.
behavior technician or
Thank
a
you. Or a BHP, behavioral health professional, but
Okay.
basically a direct support
Hmm.
staff who's overseen by a BCBA. And ideally, we can line that up, or they already had it. We work with them to transfer this behavior plan that now is working in some fashion to them. We also do training with the parents or guardians. And then, and then we discharge and try to have adequate services in place. And that happens for about 2/3 of our kids. And I would say about 1/3 roughly, we can't get back, we can't get to home, or they didn't come from home, and instead they're going to some kind of group setting, residential treatment, group home, etc. And that can be for a variety, of reasons. We have some kids who don't have it, there is no family, there's no one to go home to, they're in state custody or whatever it is. We have other families who, even if we can get things better, it's not a tenable situation. There might be whatever's going on with the family, their own challenges. And then there are some kids, as you well know, kids and adults, as you well know, but a lot of people don't want to hear this, including state policymakers, who, even after getting a really good comprehensive treatment program, they are still presenting with some challenging behaviors and are not safe on a regular basis. Or they might do fine for a week, but then they're going to have an episode, and we are not going to keep those people in the hospital forever. So they need to be, and it's not safe for them to live with parents or aging parents, and so they need a treatment setting, a facility or home or residence that is staffed that can handle that. And that's the reality.
Yeah, of course, it's the reality we hear from these families all the time. And as we know, those placements are very scant. And when we speak with clinicians like you, one of the first things that they bemoan is what they call the lack of step down
Yes.
options for
Yes.
their patients who, as you just said, they can't live in the hospital forever, right? But they also can't go to your standard group home, or they can't go home to live with, their 70-year-old mother or whatever it is. And those options are very, very rare. It's
Yes. Yes. And I have to say, even, and it's kind of gone in waves, just here in Maine, just as a locality, there was a period where we had very few agencies that would run homes that had the skill to accept this kind of person. And then we've had periods where, for whatever reason, there were very few. And then we were already in a bad period before COVID, mostly because as I understand it, we don't run any of these homes. There are some very good agencies in the community that run them, but there had been no change to reimbursement for 10 years in Maine for it's called residential treatment in
10
Maine.
years.
10 years, no
Wow.
change. And that was pre-COVID. And then once COVID hit, as you know, and still to this day, a complete disaster. We've lost multiple agencies. They can't staff the homes. They've stopped doing it. So at this point, we have like 2 places we can turn to in the entire state of Maine if we need residential care treatment, and they're full. So at this point, you have to go out of state, and none of them are taking people. So I don't want to get too focused. I mean, hopefully COVID is horrible. Hopefully this will be a moment in history and we'll get back to a somewhat more reasonable system. But I can't help but comment that right now, it isn't that the system is broken. The system is entirely paralyzed currently. So they can't get out of the hospital, so they can't get into the hospital. And it's really a huge challenge at the moment.
Yeah, the system is paralyzed, right? That's perfect word for it. I mean, this is what we hear from not just Maine. We hear about this throughout the country. Okay, we're going to wrap it up soon, but there are a couple things I want to do some rapid fire questions. Now, you are expanding. Actually, you've created something called the Glickman Lauder Center. Can you tell us a little bit about that?
Yes. So I mentioned this continuum of care, and we've been kind of growing it slowly over the last 15 years, but it was spread across multiple sites, some of them not great buildings, kind of taking whatever we can get. And we were so lucky that we got the organizational support and the community support to raise a bunch of money and build a whole new outpatient center, which is called the Glickman Lauder Center. And so we were able to both bring together a lot of these programs under one roof, which is hugely beneficial for families and for us, and also expand what we were doing. So we doubled the size of our outpatient clinic and expanded into serving adults in our outpatient clinic. So that was with this latest move. As recently as a couple of years ago, we were really not serving adults. So that's obviously a very important growth for us and a huge need in the community. So it's a really exciting step for us. And also we do research, and we also train providers. We train BCBAs and speech and medical students and et cetera. And having a really excellent center really supports that training and the research.
Yeah, that is just incredible news. So the power of generous philanthropy, great news, and step in the right direction. I hope we see a lot more of that across the country. Now, you mentioned research. So there are two things I want to just focus in on that. First of all, you've published research that talks about the dearth of research on severe autism. Would you mind just saying a word or two about that?
Sure. Yes. I mean, since we do this work clinically and we do research, we got interested in sort of, well, how well is this population of people with more severe autism and other developmental disabilities being attended to by the research community? And because everyone kind of knows, I think, or is aware that they're not getting a lot of attention, but it actually hasn't been shown that often. And so, and you need to show things. And so, so we took a look at, so we decided to focus on treatment studies, since those are in some ways, very impactful. And so we surveyed all the treatment studies that have been done in the last 20 years. And basically what we learned was what we kind of thought, which is that the inclusion of people with severe autism in those treatment studies has dropped dramatically, actually, over the past 2 decades, to the point now where maybe a third of studies include people with severe autism. So in other words, 2/3 of studies being done currently are not on the severe autism population. They're on people with less severe presentations. And so, and it's not that they don't deserve research focus also, but these are different populations. And, one could argue that those of our kids and adults who are more severely affected should get even, not get the minority of the attention, but get the majority.
Well, a bit of good news is that a proposal that you helped with and that NCSA was partly behind is going to be a special group at the world's largest autism conference in May. So this episode will probably air in May, so probably around the time of this episode. We are going to have a special focus group about treatment for severe autism at INSAR, the International Meeting for Autism Research, which will be in Austin. So that will be, I think, a step in the right direction to really improve the focus on this population that really isn't, as you know better than anyone on the planet, in desperate need for meaningful treatment to alleviate these very severe symptoms. Last question, what do you think about the term profound autism?
I think generally, I think it is helpful that term came out in the Lancet Commission report, not per se because that term is better or worse than severe autism, but rather just the recognition that there needs to be some kind of recognition that we have very different groups of people with autism, in as much as we can group them. And we can't let the spectrum and the desire to be inclusive, which are laudable things, but we can't at the same time let those things get in the way of people getting the attention, treatment, and needs that they have met. And so it seems to me that we can do all of these things. And so I think some definition around different ends of the spectrum is helpful, because really the treatments are different, the needs are different. So why would we approach it all as the same thing? And the fact that back in DSM-4 in 2013, the fact that one could not reliably diagnose Asperger's versus autism versus PDD, that was true. So clearly that system wasn't exactly working, but it doesn't mean that then what we've gone to now as just the spectrum is necessarily the most productive way to come at it either.
Yeah. Thank you for those words. Yeah, absolutely. We agree. The needs of a kid like my son Johnny, who's 23 and nonverbal and really can't do a single thing to care for himself, completely unlike the computer programmer at Microsoft who has social sensory difficulties. There's no reason for them to be given the same label or to be approached the same way in terms of research or treatment or policy. So yeah, definitely. So thank you. I know that our time is short today. Hopefully we'll have you back on the show. We'll hear more about what you're doing. And we will, by the way, people, in the show notes, we'll put links to things we discussed today, so you didn't have to write everything down. And Dr. Siegel, thank you so much for joining us on Autism Confidential.
Thank you, Jill.
All right.